All right, it's 1 minute after, so I think we'll go ahead and get started. First, welcome everyone to our Center for Pharmacy Practice Innovation monthly seminar. My name is Dave Dixon. I'm the director of the Center for Pharmacy Practice Innovation and an associate professor at Virginia Commonwealth University School of Pharmacy. It is my pleasure to introduce our speaker today. Dr. Tsuyuki is currently professor and chair in the Department of Pharmacology in the Faculty of Medicine and Dentistry at the University of Alberta. He's also the director of the Epicor Center in the Department of Medicine. He has received numerous awards, including being recognized as a fellow of the Canadian Society of Hospital Pharmacists, the American College of Cardiology, and the Canadian Academy of Health Sciences. And in 2005 was named the Canadian Pharmacist of the Year by the Canadian Pharmacist Association. He is also the president, currently the president of Hypertension Canada. His research interests include interventional health services research and the provision of support for other researchers and training the next generation of health researchers, which is provided through the Epicor Center. So let's welcome Dr. Tsuyuki to give a presentation, and then we're going to follow with some Q&A and discussion. Welcome.
Great. Well, thanks so much. Can you hear me? Yeah, excellent. All right. Well, thanks again so much for inviting me. It's a huge honor, and I guess this is a Zoom thing now where we can be all these different places without having to travel. Although I kind of miss traveling as well. So I am going to speak to you about advancing pharmacy practice through independent prescribing, from evidence to implementation. I almost said inflammation. But I'm going to talk about our experience with independent prescribing here in Canada, using the example of hypertension. Here are my disclosures. I've received investigator-initiated grants from Merck, AstraZeneca, Sanofi, Pfizer, anybody that will give me money. I have done some consulting for Emergent Biosolutions, Shoppers Drug Mart, which is a pharmacy chain here in Canada, and HLS Therapeutics. I'm the editor-in-chief of the Canadian Pharmacist Journal, and I own a consulting company called Smart. All right. So I think it's probably very obvious to you, but I'll just start off by saying, well, why pharmacists and hypertension? I'll speak briefly about the evidence for pharmacist care and hypertension, both from systematic review, but also our work on independent prescribing in hypertension and cardiovascular risk reduction. And along the way, I'll put a few things that we've learned and maybe some things that we can discuss about implementation. So why pharmacists? Well, as you know, primary care pharmacists, and we're starting to use the term primary care pharmacist as opposed to community pharmacists now, because we are the front line, in particular during COVID, or very much front line, and are highly accessible in the community where hypertension arises and is, or as it turns out, often isn't treated. People see their pharmacist much more frequently than they see their physician, and so therein lies an opportunity. And hypertension, I think, is a great example because it's asymptomatic, so people don't know they have it. It's pretty much all drug therapy, and who knows drugs better. The diagnosis and the monitoring is quite simple. It's measuring blood pressures. It's pretty simple. And of course, there's really good evidence for that, especially with a full scope of practice. So let me just stop and cover some terminology here. So we say full scope of pharmacy practice, and we say that is the standard of care. You'll note that we don't, we think words matter. So we don't actually say, we try not to say expanded scope of practice, because expanded makes it sound like it's a luxury and it would be nice to have. What we say is that a full scope is what every pharmacist should be able to do, and in fact, what the public should be able to expect from a pharmacist. And so we define a full scope as injections, not just immunizations, but travel medicine and other injectable medications. Prescribing, which, as you know, is a spectrum from authorizing refills to adapting prescriptions written by somebody else, but also independent prescribing and deprescribing. Laboratory tests, ordering lab tests, being able to obviously view laboratory tests and interpret them, and then disease management, which could be screening, prevention, chronic diseases, and acute diseases as well. So I think every international speaker has to have a map. And so I'm going to talk about the scope of practice in Alberta. So Alberta is here. This is the Rocky Mountains. This jagged line here is the Rocky Mountains. And Edmonton is the capital city, which is right around the E in Alberta there. And of course, you guys are over here in East Virginia. All right. So the scope of practice in Alberta involves injections. So any kind of immunization or any kind of injectable medications. You are not automatically granted that privilege. You have to take a course and be certified for it. It's just a weekend course. And all of our students, when they graduate, are already injection certified. So they do automatically have that just because they get that as part of their program. We have independent prescribing. Everyone can adapt a prescription. That is a prescription written by somebody else. You can change the dosage, the formulation. You could even change it to an equivalent drug. Every pharmacist can authorize refills of a medication. And then independent prescribing, we are not automatically granted that privilege. You have to apply for it. And so you have to be in practice for a minimum of 1 year, and then you have to demonstrate within that practice. You actually have to submit three cases of real patients that you've taken care of so that a panel can review it and see what your documentation is like, see what your decision making is like, and so on. The uptake of this, so it's been going for a little over 10 years now. The uptake was quite slow at the beginning because, of course, pharmacists are super cautious. But now 100% of hospital pharmacists have their independent prescribing authorization, and more than 50% in the community. So it was interesting to see it develop in hospital, because at first at hospital, everyone was attached to a team anyways. And so what we all initially thought was, well, do you even need it? Because you're on a team. But it's actually ended up being very, very important because the pharmacists do a lot of the prescribing in hospitals. So if you are unlucky enough to require cardiovascular surgery, for example, at our institution, all the prescribing is done by a pharmacist. And in fact, the surgeons don't prescribe at all, which is quite interesting. And they take them through, pharmacists take people through, right through the cardiovascular ICU, right through to discharge, and then contact the community pharmacist to pass that over. So that's been an interesting journey. All pharmacists can order lab tests. You do have to register, so it's not a qualification, but you have to register so that if you order a lab test and the potassium is 9, they know who to contact. And everybody can view lab tests. We have a provincial system that covers the entire province. So you can view anyone's prescriptions from anywhere, and you can review their electronic medical record as well as their lab tests. We are paid for disease management, and so you can do what is essentially a medication therapy management initial visit once a year, $100, and $25 for each follow-up visit, and that's available for primary care pharmacists. Hospital pharmacists can't bill for that. Interestingly, during this pandemic, pretty early on, like in around April or maybe beginning of May, pharmacists actually, they created a billing code for pharmacists to do assessment of COVID-19. And at that point, they could refer them on for a test. But then they brought in asymptomatic testing for pharmacists and a billing code for that too. And the uptake of that was very, very high and quite interesting. I went to go visit my elderly mother, and before I went, I had a pharmacist do a throat swab. It was quite interesting. Anyways, so that's the the scope of practice in Alberta. As you know, you've probably seen this 100 times before, but there are a lot of trials, a lot of randomized trials of pharmacist care in hypertension, more than almost anything. And now this is a couple of years old, 39 randomized trials. I think there's more than 50 now. And you can see pretty decent effects on blood pressure, about 7.6 over 3.9 reduction in blood pressure, and greater effects observed if it was pharmacist-led and with monthly follow-up. But none of this involved prescribing. So we set out, this is early days of prescribing in Alberta. And so we said, well, probably the most important thing we could do is blood pressure control. In these days, when we were starting this, Canada had some of the best blood pressure control in the world, but still there were about 30% that were not well controlled. And we thought, let's go out and find those people. And so we set out to evaluate the effect of pharmacist prescribing on systolic blood pressure reduction in people with poorly controlled hypertension. It was designed as a randomized controlled trial. Community pharmacies in Alberta, 248 patients with blood pressure above 140 over 90 or above 130 over 80 if they had diabetes, which is the Canadian guidelines. And they were recruited by their pharmacist. The patients were randomized to intervention or control. In the intervention group, that was the full meal deal where the pharmacist did the assessment of the patient's blood pressure, their cardiovascular risk. They prescribed, they basically took over the prescribing for that patient, did the lab testing as necessary, patient education, and follow-up. And basically, we just said, we gave them the Hypertension Canada guidelines and said, follow it. And because they're pharmacists, they did follow it. Patients also, some patients, half the patients were randomized to a control group. Now, our ethics committee wasn't very happy with doing absolutely nothing because, of course, we recruited patients with poorly controlled blood pressure, and so they forced us, and we didn't want to do this, but we had to. We forced us to have an active control group, which was, we said usual pharmacist and physician care, but really we gave them the Hypertension Canada pamphlet for hypertension. We wrote down their blood pressure measurements on a blood pressure wallet card, and we referred the patient to their primary care physician, whoever that might be. And so this is not usual care. And in fact, these were the interventions that we did in studies before we could prescribe. And so that was interesting, but that was what we had to do. In both cases, the patient's physician was notified. So here are the demographics of the patients that were enrolled. You can see the average age was about 64. About half of them were male. You can say fairly high BMIs. Quite a few had diabetes, and these were the baseline blood pressures. So they weren't hugely out of whack, but they were above target. Interestingly, about 80% were on antihypertensive therapy, and actually an average of 1.7 drugs per patient. So they were treated, it's just that they were treated inadequately. These are our main results. So this is blood pressure reduction on this axis from time 0 when they were enrolled to the end of 6 months of follow-up. The blue bar is pharmacist prescribing. The gray bar is the usual care group, which is our active control. So systolic blood pressure, you can see actually in the control group, the blood pressure actually did come down quite a bit, 11.8, but it came down more when the pharmacist took over the prescribing, 18.3 millimeter reduction in blood pressure. That difference between the two after adjustment was 6.6 millimeters of mercury, and as you can see, statistically significant. Similar sorts of reductions in diastolic blood pressure, and your odds of achieving the target blood pressure as defined by Hypertension Canada was 2.3 times higher if you were in the pharmacist prescribing group. So let me step away from that and talk about what we learned from this. So this took a long time to recruit to. And one of the things that we realized was that pharmacists needed a lot of support to do this. So there was a lot of hand-holding. We visited them very frequently. We stalked them Because, pharmacists are used to sitting back and waiting for people to come to them to say, can you help me with this problem? But because hypertension is asymptomatic, they didn't know to come. So we actually came up with a whole case finding strategy for this. So it was as simple as, if you want to focus on those with diabetes, run a list of people on metformin. And you've got thousands of them, and start with them, because chances are they have hypertension, and chances are they're not controlled. And so, just things like that weren't intuitive for pharmacists. We also gave them a hotline for clinical questions. So I had several hypertension physicians that were on board, and we fielded most of the questions ourselves. But in the situations where it wasn't so clear, we'd get a physician involved, and they liked having that hotline. Interestingly, what didn't work, so I haven't talked about this because it of course didn't work, so why would I tell you about it? But there was actually a second randomization in this study where we randomized half of the group, the intervention group, to payment for performance, and the other half was just regular fee for service. So what we did is we took what the physicians would be paid, and that was the payment, that was the fee for service. We took a payment for performance where you could receive, to make a long story short, up to $850 in 6 months if you got your patient to target. And it had no impact at all, nothing. So it either means that pharmacists don't care very much about money, or that they didn't know that we were giving them money, or the money just went to the boss, maybe. Although we actually broke it down by those pharmacists that were participating that were the owners versus those that were employees, and there still wasn't any difference. But then you're starting to slice it awfully thin at that point. So anyways, that didn't work. One of my colleagues, Carlo Mara, had suggested that we do an economic evaluation. And so simplistically, we said, well, it would probably cost something to roll out a program like this. But if we rolled it out and we got similar results as to reaction, what would we see? So there'd be certain costs to train the pharmacist. And we said, arbitrarily, we said it'd be about $1,000 to train one pharmacist to do this. We'd have to pay pharmacists fairly. So we said, let's assume that we're paying them the same as a general practitioner would get for those providing those services. And then we even said, it's likely that the pharmacist would be more aggressive, so more drugs would be used. So we said it would be about $30 more per patient per month for drug costs, even though they're actually covered by our government anyways, but we just put that in there anyway. But then there would be some downstream benefits, because you should see quite a large reduction in strokes with an 18.3 millimeter systolic blood pressure reduction, reduced myocardial infarctions, and reduced kidney failure as well. And there's standardized costs that are calculated for those. And we looked at it both by the individual patient level and at a population level. And so I'm not an economist, so I like to look at these things kind of simply. And, if you're evaluating something, the cost could be higher or they could be lower. The outcomes could be worse or they could be better. And so, as you know, most new things, drugs, interventions, surgeries, have a higher cost, but there's a better outcome. And then you have to decide, is it worth it? If the cost is higher and the outcome is worse, well, that's kind of the no-brainer quadrant where there's no decision to be made. You just wouldn't adopt that new therapy. This is a bit of a quandary. If the outcome's worse, but the cost is lower, I don't think anybody really wants to make a decision there. And then this is the other no-brainer quadrant where the costs are lower and the outcomes are better. And of course, the reason why I show you this is because a pharmacist's care does produce better outcomes, and it actually does save money. So on an individual patient basis, now this is the Canadian healthcare system, it would save about $6,364, which sounds kind of pretty minor. But if you were to apply that to half of the Canadian population, so we made the assumption that if we rolled this out across Canada, not every pharmacist would participate, and not every patient would actually go to see their pharmacist. But So we just said, well, what if we rolled it out to half of the Canadian population who had uncontrolled hypertension? If we did that, we would project about 500,000 fewer cardiovascular events and about 1 million life years gained and a cost savings of $15.7 billion Canadian, which is about 12 billion US. So better, and it would save money. An interesting simulation anyway. So what happened then was, so we did this, we published it. My boss at the time was the chief of cardiology for our institution. He got a promotion to now be in charge of cardiovascular care for the entire province. And so, when I gave my annual report to him, I wasn't sure that he really got what I did. But then he came to me when he got this new position and he said, well, we did our strategic planning and our most important thing is to reduce cardiovascular risk across the whole provinces. So we said, that pharmacist thing that you do, and, kind of with the pointy finger like that. And he said, could you do that for cardiovascular risk? Because we had also done trials, randomized trials of dyslipidemia management by pharmacists and diabetes management and so on. He said, could you put that all together, the whole enchilada? Could we do it? And I said, of course we could. He said, well, we'll fund it if you can do it. And so I said, great. So this was the birth of the REACH study. So 723 patients at high risk for cardiovascular events. You'll see that the patterns are quite similar in the way we design these things as in the reaction study. So 723 patients at high risk, those with diabetes, chronic kidney disease, which is a group we never focused on before, but as you know, they are at high risk for cardiovascular disease. Those with established vascular disease and those who were primary prevention but had a high Framingham risk with at least one uncontrolled risk factor, which I tell you excluded nobody because risk factors are generally poorly controlled. And they were randomized to an intervention or control. And again, this is sort of similar. Full cardiovascular risk assessment by the pharmacist, patient education, prescribing by the pharmacist, lab monitoring, and monthly follow-up for 3 months. And again, we just took all the relevant Canadian guidelines and we threw them at them and said, just do it. And they did. Or they got randomized to control, which was usual care. Graphically, this is what it looked like. This is the 4 high-risk groups. We did a baseline assessment and what we did here is we calculated their cardiovascular risk. So their risk for an event over the next 10 years. Then they were randomized to the intervention or control. And we designed it. So ours is called a comprehensive annual care plan, which is what you would call MTM. And so we just used the system that we already had and told them, look, but you got to focus on cardiovascular risk reduction. Then we did follow-up monthly for 3 months. Now, you might say, well, 3 months is awfully short. But again, we ran into problems with not just our ethics committee this time, but the pharmacists are starting to get wise to this. And they said, wait a minute, I am not willing to provide usual care to my high-risk patients. So go away. So we negotiated, actually, because I wanted this to be a 1-year follow-up. And they beat me down to a 3-month follow-up, which, as you know, for cardiovascular risk reduction is not very long, but it's kind of what we had to do. And then we had to agree that the control group could be crossed over to receive the intervention at the end of their 3-month follow-up as well. The outcome our primary outcome was change in cardiovascular risk from the baseline to the end of 3 months. All right. So the intervention was basically an MTM consultation, but focusing on blood pressure, waist circumference, weight, and height, lab assessment, cardiovascular risk assessment. I'll show you that in a second. Treatment recommendations. We actually didn't require that they prescribe in this study, but they all did. Because you can make recommendations so you're blue in the face and nobody does anything. So they just took the responsibility and did it. Regular follow-up every 3 weeks. So this is a screenshot from the cardiovascular risk calculator that we created for people. And so we knew that people don't understand risk very, very well. So if I said your risk is 17%, they'd say, okay, is that good or bad? Like compared to what? So we turned it into a really simple, just a kind of a green zone, an orange zone, and a red zone, and thinking that people could understand that better. And that in this particular case, that's 30% is the risk. And then the programmer that we had hired to do this came up with this idea, and because as you know, these are all just formulas. So he suggested that we put in this donut what was driving that risk. And so in this particular case, you can see that smoking in the purple is driving 54% of that risk. And the systolic blood pressure is driving about 22% of the risk. And what is that one? That one's total cholesterol is driving another 22%. And so this way, the pharmacist actually used it to speak to the patient. And, you know, somebody might say, well, I can see that most of my risk is actually coming from smoking, but I'm not going to quit smoking. So what's the next best thing? And so they might focus on their blood pressure. Now, what we did, what was behind this that you can't see was, as you know, the Framingham risk score doesn't work well for patients with diabetes or patients with established vascular disease because it underestimates their risk. So behind this risk engine, what we did was, if you put in the demographics and if you say diabetes, it automatically defaults to the UKPDS risk calculator. And if you said vascular disease, then it defaulted to the SMART risk calculator, but it all looks the same here. This was the thing that we thought was quite neat, is you've input that their systolic blood pressure is 153, but what you can do is you can actually change it in real time. So if this patient said, well, let's work on my systolic blood pressure, you could mouse over this and drag it down, let's say 8 millimeters. And you can actually see in real time the meter go down, right? And that turned out to be very motivating for patients, and the pharmacist liked it too, right? And you could say, well, if you quit smoking and you just click on this to suddenly make them a non-smoker, then you see it wildly, go down. So that ended up being a really interesting thing. If any of you are interested, that's the link for it. We made it freely available to people, and we're just about to launch it for iOS as well as a mobile app. Okay, so sorry, that was the intervention. Control group was usual care. Here are the demographics. So the average age was 62, 58% were male. Remember, you had to be one of these high-risk groups to get in. So lots of them had diabetes, lots of them had CKD, chronic kidney disease, and you can see 220 had vascular disease. And it was harder to find those patients that were high risk in primary prevention. You had to have an uncontrolled risk factor, at least one, to get in. So 79% of them that had diabetes had a poorly controlled HbA1c, 72% had uncontrolled blood pressure, 58% had uncontrolled LDL cholesterol, and 27% were smokers. So you can see, and obviously they don't add up to 100, but some people had more than one. Okay, little sideline. So as we were developing this, one of my co-investigators, Dr. Hemmelgarn, is a nephrologist, and she was head of public health at the time, and the School of Public Health. And she said, we've been creating these guidelines for chronic kidney disease screening, and we've been rolling it out to family physicians, and we've been doing it for years, and it's not affecting anything. So the nephrologists were upset because the only time they see a patient is to a consult for venous access, at the point of what kind of dialysis is it going to be, and they're frustrated with that. So she said, we're just about to release the next version of it. Do you think pharmacists would do it? And I said, well, absolutely, because it's quite simple. And so we actually incorporated this into our study design because we had to do laboratory assessment anyways. And so we took the first, the 720 patients, and we did a real simple screen. It was a urinary albumin to creatinine ratio and a serum creatinine. That's all it was. And the pharmacist did that in everyone. And in this high-risk group of patients, you can see that 39% of them did have chronic kidney disease. We looked a little further to see, did they know they had chronic kidney disease before? And the thing that was really surprising to us was that 40% of those patients with CKD never knew they had it. And it was the pharmacist actually that diagnosed it for them. And so, when we first got the privilege to order lab tests, there were a bunch of people that said, oh, the sky's going to fall and, it's going to be terrible. Well, here's actually some evidence that pharmacists ordering lab tests is not such a bad thing. Okay, this is the primary outcome for the REACH study. So this is their estimated cardiovascular risk. So the risk of heart attack, stroke, cardiovascular death. And the gray is the usual care group, and the blue is the pharmacist prescribing group. And so you can see baseline to 3 months. And you can see there's a reduction. It works out to a 21% relative risk reduction, a 5.4% absolute risk reduction. And then here's the individual components of it. Blood pressure was reduced 9/3, and the LDL cholesterol was reduced. And in those with diabetes, the A1C was reduced about 1%. And 20% reduction in smoking. So just quickly, one of the things that we did was we actually had another research group at the University of Calgary talk to the patients that were in the study to get an idea of what they thought. And so basically it boiled down to 3 different sort of themes: the relationship between the patient and the pharmacist, healthcare system characteristics, and the patient's reaction. So patients were extremely supportive of this pharmacist full scope of practice. Most of them had not even seen that before. And they said things like, oh, this is the first time anyone has ever explained any of this to me. And they really, really liked it. The stories went on and on. It was just amazing. But they said, we shouldn't cut the physician out of the loop. And in fact, we don't. So they were actually reassured that the pharmacist was communicating every change that they made to the physician. I mean, we don't ask for permission, but it is a good practice to let people know what you're doing and why you're doing it and what your plan for follow-up is. And in fact, that goes along with our prescribing authorization. It's best practice to do that. They talked about the relationship with their pharmacist and the compassion of the pharmacist. And it was just, there's a lot of stories that went along with that. And it was really quite amazing that they really, really loved it. We did a cost effectiveness analysis, and bottom line is if we rolled this out to 15% of patients across Canada, it would save $4.4 billion. So what did we learn from this? What we learned was that this online cardiovascular risk tool, which is called EpiRisk, was really popular and very empowering for the pharmacists because they had something that they could talk to, and they could print screen before and after, and they really liked that. One of the things that we're working on right now is a patient portal so people could actually calculate their own cardiovascular risk and play with it. And the patient satisfaction with their care is an important outcome that we didn't always measure before. And yet that's actually some of the most powerful stories. So we always include this now. Okay, so it's all nice to have randomized trials to be able to prove that if a pharmacist did this, here'd be the outcome. But where pharmacy practice always falls down is in implementation. So we publish it, and great, you get that on your annual report. But what about actually implementing it in the real world? And that's something that we're working on now. I don't think we have all the answers, but as you know, the barriers are pharmacists' mindset, corporations controlling everything, the culture of pharmacy, which isn't always patient care focused. Pharmacists lack confidence, and they need the processes of care that they don't necessarily have at their fingertips. So what we're doing is a couple of things. We are working with Hypertension Canada. We're developing a certification program for pharmacists, and we're redesigning MTM for chronic diseases. So I'll just speak on each one of these very quickly. So Hypertension Canada is just the not-for-profit organization for hypertension in Canada. And what we did was we developed a certification program. So we're going to actually certify pharmacists in hypertension management. And so Hypertension Canada, we've been working with, basically we take the Hypertension Canada guidelines and built a program around it. It's facilitated by hypertension experts, and it has two levels. The first level is just sort of the fundamentals. What is hypertension, the epidemiology of hypertension, and how to properly measure blood pressure. And then the second is actually taking care of patients. And so as part of this, you actually have to enroll your own patients. And in fact, the final exam is 3 cases of your own patients that are anonymized. And they gets graded by expert facilitators. Interestingly, I was able to convince Hypertension Canada, this is before I was the president, by the way, I was able to convince them that we'd only roll this out to pharmacists in the first year and a half. And then physicians want to take it, but we're not going to let them until year 2. So I'm not going to go into all the details, but basically there's 4 major modules. The first 2 modules are level 1, and the second 2 are level 2. And so I guess some of the features of that. So when you are learning how to measure blood pressure, what you have to do is you have to take a video of you taking somebody else's blood pressure, and it gets graded for all the appropriate points. Like, are you using a validated monitor? Is the cuff at heart level? Are you talking to the patient at the same time? You know, stuff like that. And you get 3 attempts to get through that, and you submit that video online, and it gets graded. And then, as I mentioned, at the end of module 4, you submit your own patient cases. And we use our online delivery through the University of Alberta. We also have this unique opportunity that because we created the thing, we can sort of control how it's rolled out. And so we're actually doing a randomized trial, which we've just started last month, where pharmacists and pharmacies are allowed to take the course, but we're controlling how they take it. So they get randomized in a stepped wedge cluster randomized design, where so group 1 gets the course right away, and they enroll their patients over, as you can see, this amount of time. Group 2 is control, so they are not allowed to do anything with their patients, but they enroll them so we get an idea of their baseline blood pressure. And then in the second period, they're allowed to take the course. And then group 3, you can see, is allowed to take the course, but several cycles into it. So they provide the control groups here for the intervention. This is just one way that we can actually evaluate it. So we have 75 pharmacies and 145 pharmacists that are taking part in this. We had to turn away another 100 because they all want to do it. But it's a good problem, I guess. And the change in this, we're going to evaluate the change in systolic blood pressure in their patients. So it's basically looking at the blood pressure change from an educational program. Last thing I'll mention is that, and this is probably a bit difficult for you to see, but we're working with our Alberta Pharmacists Association to redesign the MTM program, which we call something different, but essentially I've translated it for you here. And some big evaluations have been done using administrative data that shows that it has not much impact, and pharmacists are terrible at enrolling the right kinds of patients who need it the most, and almost 0 follow-up. And so the blue or the green parts here are actually, we're going to involve the technicians. We have regulated technicians that can do this. And so they're actually the ones that are identifying the high-risk patients, and they're putting it into a system. And the orange is what the pharmacist does. So the tech sets up the visit, the pharmacist does the visit. Patients input their own outcome measures, patient-reported outcome measures before their first visit and then after each visit. And so we can follow people along longitudinally. And so this is the tech supporting the pharmacists for their clinical role. So we're discussing this right now. It's not in place yet. So let me just finish up by saying that a full scope of pharmacist practice, which is prescribing and care, using the example of prescribing and care for hypertension and cardiovascular risk reduction, does add significant value. It's supported by strong randomized controlled trial evidence. The healthcare costs, no matter how you look at them, are lower, and patients, in fact, prefer it. One of the things I didn't tell you in the qualitative analysis is some people said, I never want to go back to see my physician again, which I think, we're trying to prevent that, but they really, it shows how much they really, really like the fact that the pharmacist took care of them. And so, being able to implement this, I think, is one of the most important things that pharmacists could do, particularly in the area of hypertension, which, as you know, is the #1 risk factor for premature morbidity and mortality worldwide. So, very much a pleasure to speak to you. I'm really happy to answer any questions that you might have in the remaining time. Thanks again.
Thank you. That was terrific. So we want to make sure that we have some time here for discussion and questions. So I'll open it up. Feel free to unmute yourself and ask your question, or if you'd like, you can also use the chat box. And maybe while folks are thinking of their question, I'll maybe get us started. This is obviously great work, and I think you certainly demonstrated, a solid body of evidence in terms of, the scope of the pharmacist really mattering. When you start to think about full implementation of something like this, like what's really the 1 or 2 key barriers to implementation in your experience?
Well, I think mostly there's really one barrier, and that is pharmacists, like pharmacy itself, which tends to be overly conservative and afraid of sort of taking on new responsibilities, you can talk about corporations, all these other things, but I mean, ultimately at the core of all this, it's us, right? It's our culture that we create, and we got to get over that. So, part of it is confidence, okay, and fair enough. But if we can provide you with education that gives you the confidence, then great. And so, yeah, it's a tough nut to crack, and but it's something that I think we have to do.
Another question in the chat box, in terms of your funding sources for the studies that you conducted, I know you briefly alluded to that for the second study, but if you'd like to elaborate a little bit more on that, just kind of
Sure.
here in the United States, where funding sources for pharmacy practice research like this can be difficult to come by. So I think there's some interest in your sources of funding and how you navigate that.
Yeah, that is really tough. We, in fact, only have one foundation that funds pharmacy practice research. They do one grant of maximum $100,000 once a year, and that's it. So you can't really count on them. And in my early days, I found that when we went to our NIH equivalent, it was mostly physicians who really frowned upon this scope of practice. And so, I don't feel like we got a really fair shake. And so I have no problem with piecing it together however I can from any kinds of sources. So in the first one, in reaction, we did have funding from our federal funder, which is called CIHR, Canadian Institutes of Health Research, which is your NIH equivalent. We did have funding from them, but it wasn't enough. And so I pieced it together, and we had some funding from Merck, actually, as an investigator initiated arm's length grant. And in the second one, it was actually our healthcare system that paid for it, which is unusual. But this is something that they decided was an important thing, and they wanted to demonstrate that. So I mean, I was quite willing to take their money. And other ones we have pieced together however we could. We just did one in Pharmacist Prescribing for urinary tract infections, and it was actually the provincial advocacy body for pharmacy that stepped up and paid for it. Which that's the first time I've ever seen them do something like that. But good, good on them, because I mean, they said, we need to get some evidence, because at that point they could do it, but they were not remunerated for doing it. They had to actually charge the patient. And so, that was interesting. And they haven't quite gotten that yet, but they're still pushing for it. At least they've got evidence now. Bottom line is I'll take it wherever I can get it, because it is tough. It is very tough.
Yeah, definitely those non-traditional sources of funding are typically the way to go. The NIH route here is also challenging. Really depends on the study section, and there's a lot of nuance there that you've got to think through.
Yeah.
Other questions?
We have another one in the chat from Evan Sisson. How does remote patient monitoring, 24-hour ABPM, home BP monitoring, et cetera, factor into your model of cardiovascular risk reduction?
That's a very, very good question, and very, very apropos for especially now. So Hypertension Canada is now, we're trying to move towards home blood pressure monitors as the standard. We're not quite there yet, but we're focusing on better measurement. So 24-hour ambulatory blood pressure measurement, we are trying to promote that a lot. And in fact, a lot of pharmacists are doing those, which is quite interesting. But we are definitely moving towards that, particularly now in the pandemic where there's less face-to-face contact. I think we're going to have to do that. So it'll be interesting to see how that happens. I know there was a paper that came out, I think about 2 weeks ago, stating that in the United States, the number of blood pressure visits during the pandemic has been reduced by about 50%. And, there's no indication that has reduced blood pressure control, but it's not going to make it better. It's going to make it worse, right? It's just that they weren't able to measure it at this point. So.
Absolutely.
Yeah, that's the future, is home blood pressure monitoring.
Yeah, I think the follow-up piece is critical with hypertension, right? It's difficult to get it controlled if you're not following up patients and measuring and monitoring.
Absolutely.
Another question here regarding what were the main drivers or what do you believe were the main drivers of lower healthcare costs that you found? So, is it just better incomes? Better outcomes? And then, what about the aspect of pharmacists potentially competing with physicians? Were they charging less per hour? Are they less expensive? Kind of thinking more, I guess, about that cost analysis model.
Sure. Well, I mean, if you think of the equation as having two sides, there's a cost to provide the service, which includes how much you're going to pay the pharmacists, versus the benefits that you accrue as a result of that. So, I mean, it's incredibly expensive to have a stroke, because not only the acute care, but the aftercare and the rehab that has to happen. Myocardial infarction and revascularization, of course, is super expensive, and chronic kidney disease and dialysis, is very expensive as well. So it doesn't take much. If anybody's interested, we actually created a simulation where you could put in your own costs. And the right now the data that we have is Canadian data. And if you you can dial in like, for example, if you wanted to pay pharmacists $1,000 per patient per month, it actually still saves money. Not very much money, but you can even put some ridiculous numbers in there and it saves a lot of money. I had a postdoc fellow who was from Japan, and so we actually reran these numbers using Japanese numbers, because they have a high incidence of hypertension and almost no control. For some reason they just don't control it, and a much larger population than Canada has. And so when you put those things into the formula, we worked it out using exactly the same assumptions. And there's no reason to think that Japanese pharmacists wouldn't be as good at it as Canadian pharmacists. And we worked it out, and the numbers were so large. It was 22 trillion yen that you would save. And of course, that's meaningless to me. So to put it in context, it would have paid for the Japanese, the Tokyo Olympics 18 times just by doing that. And so we published that. And no, it hasn't made any difference, but it's interesting that with those kind of relatively conservative assumptions, I mean, you can save a lot of money. So I think we just got to get it to the right people who can make those decisions.
Another question here. So thinking about the lifestyle interventions that maybe the pharmacist also made as part of your overall intervention, have you done any work looking at the impact of the intervention on lifestyle modifications and the role of the pharmacist in that aspect?
Yeah, well, of course I didn't talk about that, but the lifestyle part is part of our guidelines. It's the first thing that you do, and so it's there. As you know, it's important. The effects are kind of modest because adherence to it is not great. But pharmacists are surprisingly very interested in lifestyle modifications, and that, so we always integrate it in because it's part of our guidelines anyway. We aren't able to parse out how much effect that has, because of course we're layering on prescribing interventions on top of that, so we don't exactly know.
These are great questions. Any other questions from the group? Teresa, are you trying to ask a question? You're muted.
No, actually, I was just well, I was just impressed with everything, and I did take some notes, but I didn't want to monopolize the whole conversation. But with regards to the COVID testing that you guys are doing in community pharmacy for asymptomatic and both symptomatic and asymptomatic, is it just the sample collection that the pharmacists do, or how is the articulation with the laboratory, and then how does that information get fit into the Alberta-wide EMR? I was curious to learn more.
Right. So pharmacists were only doing asymptomatic testing. If you're symptomatic, you had to go to one of the hospitals or special clinics that they had set up. So it was only for asymptomatic testing. And interestingly, last week they stopped that completely because there were so many asymptomatic tests and the yield was so low that it's actually impairing the ability of the provincial labs to actually keep up with the symptomatic testing, which is more important. So as of last week, they suspended it. But it was an interesting thing where, so this started in July, and I was about to go and visit my elderly mother. And so I went and had a test, and I ended up speaking to the pharmacist. And so my next editorial in the Canadian Pharmacist Journal is actually a video of me interviewing this guy. And I said, well, why do you do this? Because all this, need for personal protective equipment and, this new thing. And he says, well, we're in the community. We're the only ones still open, and we got to do it. It was really interesting to hear his experience. And basically, he was spending 8 or 10 hours a day just swabbing people, in the height of it. So that was really interesting. And in fact, he was doing actually a lot of physicians and nurses as well who wanted to get tested. So it was not a walk-in thing. You had to make an appointment. And you had to wear a mask and all that, and yeah, it was interesting. A really good example of somebody of people stepping up, during the time of crisis.
Absolutely, really, really interesting. And then one last question, if I may. In your REACH trial, why did you, and maybe I misunderstood this, why did you not use, I mean, how many pharmacies were included to begin with?
There was around 60.
Okay. And did you go with a cluster randomized control trial or just an individual based randomized control trial?
That one was a per individual randomized trial.
Okay. Okay.
Yeah. So at the beginning, we had to get pharmacists' agreement that half of their patients would be randomized to usual care. But of course, that compromise ended up being only for 3 months.
Okay.
Right. So essentially what we did is the patients upon randomization got an appointment tomorrow or 3 months from now.
Okay.
That's kind of how we rolled it out.
Perfect. Thank you so much. And congratulations. And thank you for coming. This was
Oh,
amazing.
thanks for having me.
All right. Well, I think we're at the end of our time. Ross, thank you so much. This was really terrific. Gotten a few private comments even from folks saying how much they enjoyed your presentation and sharing your experience and the great work that you've done. So thanks for taking the time today to speak with us. And thank you all for coming. And we look forward to seeing you next time.
Very good. Thanks, everybody. My pleasure. Take care.